Hello again, and thank you for joining us for another episode of the Oncology Brothers Podcast. I'm Rahul Gosain, and along with my brother and co-host, Rohit Gosain, today we would like to welcome Dr. Balazs Halmos, a thoracic medical oncologist from Montefiore-Einstein Comprehensive Cancer Center, to discuss the current landscape of metastatic non-small cell lung cancer with actionable mutations in first-line settings. Balazs, thank you so much for joining us.
Thank you so much for having me. I look forward to our conversations.
Balazs, welcome. We have a lot to cover in very little time, so let's get started here. So non-small cell lung cancer has been a poster child for personalized or precision medicine. A few years ago, we used to struggle with getting NGS testing done before IO exposure, but now we've actually gotten better in that. However, now the struggle is going through these complex and dense NGS reports. Well, let's put up a hypothetical case. You have a patient with metastatic non-small cell lung cancer involving bones. Liquid NGS report is negative for any actionable mutation, but initial lung biopsy does reveal common sensitizing EGFR mutation. Balazs, can you briefly touch on how you are deciding your first-line treatment here, and especially when you're talking about the data from single-agent osimertinib with chemo based on FLAURA2, and the data we have from Balazs based on Mariposa, which is not FDA approved?
Yeah, excellent question. And what a start to our conversation here. Certainly, our treatment landscape used to be very, very simple in a way. If you find a patient with advanced lung cancer with an actionable EGFR mutation, it's osimertinib. You didn't have to, use a single brain cell for that decision on a certain level. And now suddenly things have changed, but things have changed for the better, although, certainly there's kind of complications as to, having to extend our visits, by an extra couple of minutes to cover that discussion carefully. But both the FLAURA2 and the Mariposa studies do argue that as much as osimertinib is a great standard of care, it's not the best standard of care for every single one of our patients. So now we have to start thinking about some unique features of the tumor, the molecular landscape, and the patient himself or herself to be able to kind of categorize that patient as having high risk or low risk EGFR mutated disease. Let me just highlight, that as it turns out, EGFR exon 19 deletions, those tumors do better than, patients, harboring, tumors with L858R. Patients with certain metastatic sites, do more poorly, brain metastasis, liver metastasis. Patients with co-mutations do more poorly, such as P53. So there's a very specific factors that we can consider to identify a patient where maybe single agent osimertinib is okay, but we could potentially do better. And that's where adding chemotherapy to osimertinib as in FLAURA2 definitely yields a progression-free survival advantage with some trends towards OS benefits as well. And for these high-risk categories, suddenly the PFS benefit is in the range of like a year added, without progression. That's very substantial. So I would think that currently, if you're facing a patient with brain mets, with L858R co-mutations, suddenly you want to bring the combination into the conversation, where your patient might or might not, wish to pursue that regimen dependent on comorbidities, age, frailty, and personal decisions. But at least having that conversation, so through shared decision making, you could make the best decision is important. And soon enough, we might see the Mariposa regimen being approved as well. That will complicate the picture further. I think the initial reaction to Mariposa has been a little bit negative, despite sort of the positive data. The adverse event profile of the regimen is a little bit frightening frontline. Infusion reactions, very substantial dermatological adverse events, high risk of thromboembolic events, sound frightening to the practicing clinician like myself, certainly. But we've seen a bit of a highlight at ASCO that switching to a sub-Q version of amivantamab suddenly reduces the infusion reactions and the thromboembolic events greatly. And strangely, surprisingly, but in a way, pleasant way, it actually does you a better survival as compared to the IV version. And the sub-Q version was filed with the FDA just a couple of days ago. So I think when the approval is in place and the sub-Q version is available, suddenly we'll start looking at the regimen as well and integrate that similarly, because yes, indeed, the outcomes can be better for very specific patient populations.
Balazs, thank you for covering that. There's a lot to unpack here. Chemo with osimertinib or amivantamab, let's say this subQ formulation, improves PFS, there's OS hint here, but the convenience of single agent osimertinib as an oral agent is priceless for our patients, right? So when you're making that decision, again, you brought this up, patient-centered or patient-shared decision is going to be so important. There are going to be patients that are going to do just well on single-agent osimertinib because then you have potential good second-line, third-line options as well, whereas in selective patients, giving the combination is going to be the key. Coming back to this hypothetical case, Balazs, a patient with bone disease, let's say you start them on osimertinib or a combination based on Mariposa, because even that selected patient population was high risk. What is your next treatment option going to be?
Okay, a great question, and a very much evolving landscape. So you always need to kind of be, ready, to make different changes as we learn about new data, and maybe we'll have new FDA approvals. For example, just in this context, within just a few days, we could see the approval of patritumab, the anti-HER3 ADC. That's currently a third-line agent. I'm not considering it for the patient that you just presented, but it will add to those sequencing options that we'll have for our patients. At the present time, and this is not just for EGFR, but for any patient on a targeted agent, first decision point is, should I kind of redo molecular testing? Can I learn, from the patient's evolving, kind of molecular dynamics? Typically ctDNA testing to begin with. If that's not informative, thinking about a tissue biopsy. Are we looking at a small cell transformation? Is there a MET amplification or a secondary EGFR mutation that could highlight, different treatment options, for our patient? Also, always important to consider, is it an isolated site of progression or are we looking at multiple sites of progression? Isolated progression, many times locally ablative therapy is reasonable to consider. As the number of metastatic sites grows, that conversation becomes less and less logical, of course. And if there's multiple sites of progression, systemic therapy is the right choice. If the molecular retesting hasn't offered an easier option, chemotherapy, is the standard of care. Doublet chemotherapy plus minus amivantamab, with recent data, so that can be considered as well. And again, we'll see how the ADCs will change this landscape, very quickly with the anti-HER3 and maybe the anti-TROP2 ADCs being part of our treatment armamentarium.
Absolutely. A few things to reiterate. A repeat biopsy, liquid or solid tissue, is going to be important based on the progressive nature of the disease here. Okay, moving right along. As of now, amivantamab is currently approved in second line for exon 20 EGFR mutation, but the data, even for amivantamab with chemotherapy from Papillon study, is very exciting, and this will likely get approved in first settings. But to be honest, as a community oncologist, it feels like there are more drugs targeting exon 20 than the actual patients we see in the community. But Balazs, can we take a few minutes to touch on other uncommon EGFR mutations such as G1719X or S768, your go-to anti-EGFR in this setting?
Yeah, certainly it's very important to remember that EGFR mutations are, three different kind of buckets. One is the very common EGFR exon 19 deletions, L858R. We covered those already. The rest of the 10% comes in two different categories. And one is EGFR exon 20 insertions. That's about half of, that remaining, 10%. At the moment, we only have amivantamab as a targeted molecule for those patients. I would think that amivantamab with chemotherapy frontline in a way is the current standard of care. But that leaves a huge gap, second line and beyond. A lot of agents are being developed, certainly a lot of excitement around them, but not likely that any of them will be in our practices anytime soon. That's the reality. Now, for the rest of the 5%, those are the uncommon or atypical or also called PAC mutations, by certain classifications. For those, the FDA approval currently sits with the dapatinib, and that is a very appropriate medicine to use. At the same time, certainly has a significant side effect profile to consider. Osimertinib certainly has documented value, but that's where, if you look at the literature, now you have to go down mutation by mutation by mutation to kind of grasp, how well that, medicine could work. But certainly another option to consider, maybe with a little bit less reactivity, but, certainly a more favorable toxicity profile. And I might say that at ASCO, there was a bit of a highlight with the amivantamab lazertinib presentation from Chrysalis, that actually highlighted that this combination for this very particular category of patients can have a 17-month or so progression-free survival as compared to the 6 to 8 that we see with single-agent EGFR TKIs. And in my view, when this regimen will be approved, I definitely will be inclined to consider it for the uncommon mutation positive patients based on this experience. So just something to consider.
Absolutely.
Thanks for covering that. Especially, it is important to reiterate the importance of all these medications, but also when you're dealing with rare mutations, it is important to tie in your tertiary and quaternary centers and see and investigate if there are any additional clinical trials that could be of any assistance here. Now, switching gears to ALK mutations, the choice, along with others, the important ones are alectinib, brigatinib, and lorlatinib. We just saw an incredible update from Crown Trial at ASCO 2024 with phenomenal PFS when compared to crizotinib. But none of us, in fact, use crizotinib in patients anyhow. Balazs, your go-to ALK inhibitor upfront, and then how do you sequence your treatment at the time of progressive disease here?
Yeah, certainly, again, a bit of a shifting landscape based on just sort of transformational results from just 2 weeks ago. And, of course, we've all known that these, third, next generation TKIs are very effective. So effective that when we look at alectinib, from the ALEX study, progression-free survivals in the 3 years range. And I've been kind of joking around that it's quite impressive for an oncologist to be able to give a prescription to a patient with 35 refills and ask them to come back to your clinic in 3 years. Because yes, indeed, the medicine is actually very well tolerated and it's extremely effective. So we have a fantastic choice with alectinib. And now that's moved into the adjuvant space, where of course now we have to use precision medicine to make sure that our patients with EGFR mutated, ALK translocated tumors get considerations for adjuvant targeted therapy. But now when we look at the Crown study results, represented by Dr. Solomon just 2 weeks ago, that is truly a crowning achievement for the entire field. Because in that study, lorlatinib, this next generation TKI, which has incredible CNS activity, has shown just an unprecedented more than 5-year median progression-free survival. And I just want us to pause for a moment. 5 years. What kind of a statement is that in oncology for a patient with metastatic disease, that they can stay on their first drug for more than 5 years on average? So really stunning. And I think the stunning nature of the results has to make us reconsider. Yes, lorlatinib is a more difficult drug to give. A lot of CNS side effects, lipid side effects, neuropathies, et cetera. But maybe it's time for us to be committed to work through those side effects for at least more of our patients than in the past. And I just had this conversation actually yesterday, the first time since ASCO with a patient, and learning about the result. This patient who actually had significant comorbidities to consider, she said, I want the best. I'm willing to face the side effects. And one thing to highlight from the Crown presentation, the patients where you had to dose reduce due to those side effects, their outcome was not compromised. So I think we just need to work to find the right dose for patients, not be too worried about giving the max dose, giving a dose that's appropriate, for the patient to be able to tolerate with a functional existence. But yes, indeed, lorlatinib at the moment, gets the crown. And as a result, it has to be in our conversation as our best frontline TKI.
Balazs, thank you for covering that. But I want to reiterate a few things that you've mentioned on. There were high grade 3-4 toxicities. Almost 77% of the patients had these toxicities. So dose reduction without compromising the efficacy is so important. Another thing that you mentioned, for us in the community, it's not only about knowing that there is a drug approval, but getting comfortable around managing these toxicities. Because alectinib, as you've mentioned in adjuvant settings, based off Alina trial, is now approved. So we are using these medications earlier and earlier. And then coming back to the same thing, instead of the highest dose, selecting the right dose, we're seeing a lot more patient advocates. Jill Feldman, again, a very active voice, continues to bring this up, that for us in this community, we need to continue to find the lowest best dose that's efficacious so that we can avoid some of these side effects. All right, moving on to our next targeted mutation, ROS1 mutation and our treatment options. Balazs, your thoughts here?
Well, ROS1 fusion positive lung cancers are uncommon. 0.5% of the patient population that we see. So many community oncologists will never see one, or will see a very occasional one. But I would say be comforted that these patients tend to do super, super well on targeted therapy if you're able to identify them. So again, testing is so important not to miss out on offering a patient such a transformational drug. We have the best outcomes, with the ROS TKIs, in such patients. Actually, very few patients ultimately develop resistance. The drugs are so effective. And we just added a molecule which might be maybe the best out of the crew to the two that already, we had, entrectinib and crizotinib. Repotrectinib was just approved, based on the Trident study a couple of months ago. It seems to be extremely efficacious, being able to overcome key resistance mechanisms. It does have a very specific safety profile, though, that all of us will need to remember. It causes very frequent dizziness. And there's dizziness that in the statement of one of our patients from a few weeks ago, is dizziness to the point that they could not get out of bed safely. So it's something to consider. Again, maybe it's not for everyone, but definitely now has to be in that frontline conversation. Again, working through the right dosing, maybe starting at the more cautious dose and working your way up. If the dizziness is not a significant issue, can be a good choice for some of your patients, especially if that patient is more frail, elderly, maybe more prone to consequences of dizziness.
Thanks so much for covering that, Balazs. And important to reiterate that a lot of these medications do have toxicities, especially when you're talking about patients' quality of life and when they have to take these medications for years and years down the road. Okay, next up we got BRAF V600E mutation. As community oncologists, we have been lucky to utilize these drugs here in melanoma as well as colorectal settings. Balazs, your thoughts here, sir?
V600E is highly targetable amongst patients with metastatic non-small cell lung cancer as well. We have two combinations, BRAF-MEK combos, the BRAF-MEK trametinib and encorafenib binimetinib. To me, it looks like a Pepsi and Coke conversation. So whichever you favor, I think is fine. There's not much of a difference on paper. Encorafenib has the claim to fame that it causes less pyrexia, which can be a little bit of a troubling side effect of the BRAF-MEK trametinib combination. But outside of that, I personally have a hard time kind of separating, these combos. They're both effective. They're not as effective, though, as what we got used to with the EGFR, ALK, and ROS, patient categories. So the expectation is hopefully, significant progression-free survival of 8 to 10, 12 months. And hopefully with time, they'll do even better, for these patients. But I also want to highlight that just like Metexon 14, which maybe we'll cover, later on, some of these patients are not the non-smoker, patients, but they might have a heavy smoking history, and they might actually have benefit from immunotherapy approaches as well. So this is not that kind of intermediate tier where both targeted and immunotherapy approaches should be in the conversation. And for any specific patient, either of these, could be very reasonable.
Thanks. And what is important also to keep other side effects in mind when administering these drugs, that you mentioned pyrexia, along with that rash, diarrhea, fatigue, are a few important key side effects to keep in mind when administering BRAF and MEK inhibitors.
Balazs, you've highlighted this, and Rohit, you brought up melanoma. So the importance of use of immunotherapy is something for us to keep in mind, because we've learned that in melanoma patients that with BRAF V600E, there's still role of immunotherapy here. All right, now moving to another rare mutation, Balazs, needle in a haystack when it comes to NTRK. Have you had a patient with NTRK, and if so, your experience here?
Well, I actually did, but that patient didn't have metastatic disease, so didn't need a targeted therapy. So I do not have a personal experience with managing an NTRK fusion positive patient. They're extremely rare. One thing to remember is, if you know NTRK, you're really kind of on track with your precision medicine knowledge. So NTRK fusions occur in a bit of a tissue agnostic fashion. They are really rare in many, many very common tumor types, but they can be very common in a couple of very rare tumor types, such as particular salivary gland cancer, as well as a very particular type of breast cancer as well, a very unusual type. So there's a very particular molecular landscape there. So basically all of our patients with metastatic cancer of any type in reality deserve NGS testing to uncover these rare tissue agnostic aberrations. But when you find a patient with an NTRK fusion positive cancer of any kind, very high chance of a long-term response to one of these agents. Both of them look really good, on paper. Again, I don't have very personal experience with larotrectinib. I do with entrectinib for RAS positive patients. Larotrectinib seems to have a little bit of a higher response rate, longer duration of response, but both of them look very appropriate.
As a primary mutation up front, or every now and then, we see that as a resistant clone, as you mentioned about this early Balazs MET exon 14 skipping mutation. The choices here we have are capmatinib and tepotinib, but we again have data for amivantamab being responsive based off Carcella's study. Your thoughts here, and how do you proceed in these settings?
Yeah, this is very close to my heart because I've actually done quite a bit of work with MET exon 14. So MET is an important treatment target, but it's also a confusing one. So the one alteration that's highly actionable is MET exon 14 skipping. What that means is that there's a gazillion different mutations that can achieve the same thing, that exon 14 of MET is simply not transcribed. It's missing, from the protein in the end. So one very specific little building block is just missing. It's a shorter protein. And what's missing is a very particular residue that leads to its degradation. The good news is that with TKIs, we can target, these patients with MET exon 14. Capmatinib and tepotinib, it's the Coke and Pepsi, or maybe I should move to like bourbon and scotch. So both excellent drugs, they have CNS activity, great activity. Both of them, have side effects. MET targeting leads to very specific side effects, especially edemas that can be very bothersome to manage for patients. And, again, MET exon 14 skipping can occur in patients who've never smoked. In those, immunotherapy likely doesn't have a whole lot of value. Or it can happen in heavy smokers with a particular type of lung cancer called sarcomatoid carcinoma, where immunotherapy has a lot of value. So when we think about targeted versus immunotherapy in these cases, I think looking at the molecular profile in a holistic fashion helps. Is it a high TMB smoker or low TMB non-smoker? And I might kind of utilize that in my decision making. You mentioned amivantamab, and that's a very interesting conversation where amivantamab is a bispecific antibody against EGFR and MET. Now it turns out that EGFR and MET kind of collaborate in terms of oncogenic signaling. So blocking the activity of both actually can help in a number of different settings. One is EGFR mutated lung cancer. One of the key resistance mechanisms is MET amplification, not MET exon 14 skipping, but amplification. But it might actually help in these cases with MET exon 14 skipping as well. The reasonable response rate, and I would use that in kind of sequencing of agents, in these patients, but not front line. I think that's kind of third line after TKI, chemoimmunotherapy. Third line, I think it's appropriate to consider.
These are exciting times to be a medical oncologist. All right, before we close, can we touch on RET rearrangement? Recently, we've seen selpercatinib get approved even for RET fusion positive thyroid cancer. Balazs, your thoughts here?
Yeah, again, a very interesting target. Similar to NTRK, RET rearrangements, RET fusions can occur in a number of different cancer types. The most critical ones in terms of RET targeting are thyroid cancer, where you can have recurrent RET mutations in medullary thyroid cancer, or recurrent RET fusions in papillary thyroid cancer. So the different thyroid cancer types you want to remember, in lung cancer, we see RET fusions, not mutations. Sometimes that can be very confusing when we look at the report. If you see a RET mutation on a lung cancer report, forget it, ignore it. Okay, it has to be a RET fusion. The reason being that the RET protein normally is not expressed in lung cells. So it has to have that fusion for the protein to be actually generated and create this kind of oncogenic, chimera oncogenic function. When we find these, very small percentage. I actually do have a patient right now in my clinic who's doing very well with this, very specific RET fusion. We have two excellent drugs, selpercatinib and pralsetinib. I'm not going to go with my drink comparison here. Selpercatinib appears to be truly a little bit better, and that's kind of taken the market over to the point that pralsetinib has gotten shifted a little bit as to the company managing it. But both are very active choices. And we'll see if future generations of novel agents will also be developed.
Wow, over the last few minutes, we've covered a lot here. Balazs, thank you so much for taking the time to touch on this rapidly evolving space and reiterating the current treatment landscape, which is shifting, for metastatic non-small cell lung cancer with actionable mutations in first line. For our listeners, let us go over a quick recap. Dr. Balazs Halmos from Montefiore-Einstein Comprehensive Cancer Center, we've covered the importance of NGS testing in metastatic non-small cell lung cancer and discussed treatment options for various actionable mutations, including EGFR, ALK, ROS1, and RET rearrangements.
Identifying and targeting specific mutations is critical for optimizing treatment outcomes and improving patient quality of life. Appreciating that some of these mutations are not immunotherapy sensitive is only one part of the puzzle. Picking the right targeted agent for our patients when we have multiple options and managing some of the toxicities that come along with these agents ends up being another bigger piece of the puzzle. Precision medicine continues to transform the landscape of metastatic non-small cell lung cancer. Thank you for tuning in. Make sure to check out our other discussions in the lung cancer series. We are the Oncology Brothers.